So thank you for joining us today. We're going to explore the important intersections of genetics and genomics in the management of patients with urologic cancer, and we will review current guidelines and use real-world cases to discuss how to apply this concept in the clinical practice to optimize patient care. This is the brief overview of our agenda for this course. First, we'll talk about the basic concept of genetic risk assessment, then we'll do a deep dive into the genetics of kidney, adrenal, prostate, and urothelial cancer. I'm very pleased to introduce my panel. Dr. Maria Baker is the director of Penn State Health Cancer Genetics Program. Dr. Jonathan Coleman is a urologic oncologist and surgeon scientist at Memorial Sloan Kettering who leads the translational research effort in kidney and upper tract cancer. Dr. Siddiqui is the Director of Urologic Oncology and Surgeon Scientist at University of Maryland, who specializes in the integration of advanced diagnostic and personalized care in patients with prostate and bladder cancer. And I'm a urologic oncologist at Penn State. So to start, it's important to distinguish between the difference of genetics and genomics. Oftentimes, we use these concepts interchangeably, but there are some differences. Genetic typically refer to the study of single genes and their role in inheritance and cancer risk. For example, BRCA2 mutation passed out to families and they can predispose to prostate cancer as well as breast, ovarian, and pancreatic cancer. Genomics, on the other hand, involve the study of all genes and their interaction with each other and the environment, often focus on the somatic alteration within the cancer itself. Understanding the difference help us tailor how to use the testing. Germline testing look for inherited risk versus tumor genomic profiling help to guide therapeutic decision as well as prognostication. So why should urologists care about genetics of urologic cancer? What's the significance here? First, the heredity of urologic cancer is actually very high. When we think about hereditary cancer syndrome, sometimes we often think about breast colorectal cancer. But based on study of cancer incidence in monozygotic and dizygotic twins, we found that prostate cancer actually have the highest heritability. Almost it would be 60%. Kidney is 38%, testes is 37%, and bladder is 30%. So all very high hereditary component. What's more important is the clinical effect of finding a germline mutation in cancer susceptibility genes in patients, and that impact is actually extensive. First, you have the cascade testing. So when a patient is found to have a germline mutation, it impacts their family member who may be at risk, who may not have cancer diagnosis but they may qualify for genetic testing and enhanced screening. Second is the impact of surgery. There is prophylactic surgery to reduce the mortality of certain cancer. And one of the most famous examples is Angelina Jolie, who underwent prophylactic mastectomy and oophorectomy to mitigate the risk associated with BRCA1 mutation. And then there's enhanced cancer screening. So patients with genetic mutation tend to develop multiple primary cancers, so therefore they need to be screened and managed appropriately. Here you can see an example of a breast cancer that missed on mammogram that was picked up on MRI, which is not typically done for patients unless they have a genetic predisposition. There's also medication to reduce the risk of cancer. Tamoxifen is FDA approved for chemo prevention in breast cancer. As you can see, we have a lot of example from breast cancer, and we're going to move in that direction for urologic cancer as well, and you're going to find out some of that during this course today. And finally, if we miss cancer at early stage, there are targeted therapies such as BRCA inhibitors and immunotherapy at later stages of cancer. So now I'm going to pass the course over to Dr. Baker, who will talk about genetic counseling. Let me get your slide ready here, Dr. Baker.
Okay, thank you. Point. And advancing.
Advancing, you just click.
Okay, on the right or the left?
Mm-hmm.
Right or left?
You just click on the...
Okay, on here. Okay. So thank you for inviting me back to give a presentation on genetic counseling and testing for hereditary GU cancer. Before I get started, though, I'd really like to get a sense from the group. How many of you have access to a genetics provider to coordinate the testing in-house? Okay. There's a fair number of you. And of those of you who don't have access to a genetics provider, have you felt some pressure to coordinate the testing at the point of care in your clinic setting, and have you been able to implement that? Anyone implementing point of care testing? Okay. I can tell you that over the past couple years, I've tried to encourage some of our providers to do that, and the concern is always about the time that it might take in the busy clinic setting. But we're really going to have to think long and hard about how we're going to transition these services, because with the expanding indications, there's no way there's going to be enough genetics providers, despite the fact that we have made videos and developed brochures, and we even have developed chatbots to replace the genetic counseling that we provide up front. And I have to admit, I don't know of any other profession that is training everybody else to do their job. But the problem is, and I'm just going off topic here right now, this is my pet peeve. I've been in this field since 1985. And this profession is now 50 plus years old, and we are not yet recognized by the Centers for Medicare and Medicaid Services. And so if you are not recognized as billable providers, but yet you are the provider that has the specific expertise to educate about the benefits, risks, and limitations of genetic testing, it doesn't make common sense why that's the provider that would not be reimbursed to provide the services to your patients. So this is something that needs to change. And, you know, if we had some effort moving forward to recognize master's trained genetics providers in 1990, when they had the foresight to allocate 5% of the Human Genome Project budget to the ethical, legal, and social implications of the future discoveries that were to be made, we would not be in this situation. So something needs to change. And for those of you who are in a position to help affect that change, I would encourage you to do so. Honestly, not sure if it's going to occur in my career, but we'll keep moving forward. Okay, I'm going to get off my soapbox there. Let me just move forward. So in my presentation today, I'm going to review the traditional model of genetic counseling and testing for hereditary cancer and why I believe it's not sustainable given the expanding indications for testing. I'll discuss the evolution of multi-gene panel testing, including the pros and cons, and I'll use some case examples, and introduce some concepts about alternative service delivery models to address the challenges with access to cancer genetic testing. This field has really transitioned greatly since these genes were first discovered. In the early to mid-1990s, we had the mismatch repair genes, which, when mutated, are responsible for Lynch syndrome, the most common hereditary cause of colorectal and endometrial cancer. And no talk about the hereditary nature of GU cancer can be complete without discussing Lynch syndrome, because we know that this condition increases the risk of upper tract urothelial carcinoma of the kidneys and ureters, as well as the bladder and the prostate cancer. And shortly thereafter, in 1994 and 95, we saw the discovery of the BRCA1 and 2 genes, which are most well known to predispose to hereditary breast and ovarian cancer, as well as pancreatic cancer. But we also know that those genes increase the risk of a more aggressive type of prostate cancer. Now, the traditional approach to cancer genetic testing, which I've lived from day one, was a sequential approach. Basically, we would offer testing for one gene or condition, the gene or condition that we thought was highest on the differential after taking a thorough family history. And if we guessed wrong and we got a negative test result, After spending maybe $4,000, we were moving on to the next most likely gene or condition. It was very costly. It certainly lengthened the turnaround time of genetic testing, and it caused tester fatigue, not only for the patient, but the provider as well. And the cost was astronomical, given that we hadn't yet appreciated the significant decrease in the cost of this technology. Fortunately, in 2012, we saw the advent of multi-gene panel tests, which instead of testing one gene or condition at a time by the traditional Sanger sequence technology, instead, we would use next generation sequencing, which involves multiple sequence reads per base pair, followed by alignment of those reads for the purpose of variant calling. And in this slide, you can see a sample hereditary cancer panel. On the left, you can see a list of a number of different cancer susceptibility genes. And on the top, across the top, you can see a variety of different types of cancers for which those genes predispose to. When the laboratories developed these panels starting in 2012, they each took their own approach. I recall one laboratory that developed a pan-cancer panel, which encompassed all the genes, and you had no flexibility to remove a gene or add any extra genes. It was basically throw the kitchen sink at it and see if anything sticks. Yet other laboratories developed a different approach. They developed a variety of different panels, one that was breast-focused, one that was colon-focused, one that was kidney-focused, and you could choose a larger panel for that particular cancer or a smaller panel. The smaller panel would include only those genes for which there were medical management guidelines already developed, whereas the larger panel included some genes where we were still trying to figure out what's the best way to manage a patient should they test positive for a mutation in one of those genes. Then there were other labs that gave us as much freedom as possible to pick and choose which genes we wanted to add or not onto a custom panel. Some of the laboratories would allow you to reflex up to additional genes. Most of these laboratories are sending everybody's DNA sample down the same platform. So technically, even if you're only ordering 13 breast cancer susceptibility genes, that sample may get analyzed for 70 or 84 genes, and all the other genes that you didn't ask for, that information is blinded. So the report that is generated is only giving you information about the 13 genes that you requested. And so it makes it very easy for some of these laboratories to allow you to reflex. So a patient that didn't feel quite comfortable at the outset to choose a significantly larger panel can start very small and focused. And if we don't find a mutation when you're disclosing those results, they have up to 90 days to choose to go bigger. And those reflex results, I've seen them come back in as short as 10 minutes because nothing else was found when you unblinded the information about the other genes. Or sometimes it can take an additional 3 or 4 weeks. And that might be a situation where when you expanded to include the other genes, there were some variants identified where they needed to do a deep dive into the literature to figure out how they were going to classify that variant. And then there are some labs that would offer stat panels. And those are panels that we would use if surgery was pending. So sometimes we might order a stat panel for a patient who has breast surgery pending to help them decide whether they want to do breast-conserving surgery or whether if they had a hereditary predisposition where there was a significant chance for a new breast cancer down the road, they might choose a bilateral mastectomy. So traditionally, genetic counselors are involved on the front end. We draw a family tree by eliciting the personal and family history. We evaluate that family tree, determine whether genetic testing is appropriate to offer, and then decide what type of test is most appropriate for the patient in front of us. Whether or not that's going to be sustainable down the road, that's up for discussion. So to start out, our basic tool in our toolbox is to draw that at a minimum 3-generation family pedigree. And so we use standard pedigree nomenclature, and it's important to appreciate the difference between a first, second, and third-degree relative, not only because the guidelines are hinged upon how close the family history of cancer is to the proband, but many times it also determines whether the insurance company is willing to cover the test. For example, there's one insurance company that for years would not recognize third-degree relatives, which is a cousin or a great aunt or a great grandparent. And yet that might be the exact family history that meets NCCN guidelines, but yet the insurance company is denying the test. And then most recently in 2022, we did upgrade the pedigree nomenclature to become more gender inclusive, with now the circles, the squares, and now the diamonds representing the proband's gender identity rather than their sex assigned at birth. So traditionally, and this still holds today, we all know that most cancer is not hereditary. Most is sporadic. It happens by chance, a stroke of bad luck. But what has started to change is the percentage of cancer that we believe is hereditary. You know, we've always heard from day one, maybe 5 to 10% of cancer is hereditary. But now that we're using these next generation sequencing panels, we're finding that anywhere from 5 to 10 to 20% or more can be hereditary, depending on the specific tumor type. We still know that a significant portion of cancer is familial. So the distinction between genetic and familial, with genetic or inherited cancer, we're referring to those situations where there is a single gene that has been identified that is the major driving force for that cancer to occur. Whereas with familial cancer, I refer to that as multifactorial inheritance, where there are many factors involved, both genetic and environmental. The genetic factors are not bona fide mutations in genes, but instead they are subtle variations in genes, what we call single nucleotide polymorphisms, which individually don't move the needle at all, but collectively, when you add a number of SNPs together, can significantly increase that person's risk or decrease their risk for cancer when combined with the environmental and lifestyle risk factors. The genetic counselors also use a number of different risk assessment models to estimate, prior to testing, what's the likelihood of finding a mutation. So the PREM5 model can allow us to estimate the likelihood of finding a mutation if we enter in some of the family history information, who had colon cancer, who had endometrial cancer, at what age. And ultimately, if there's at least a 5% chance of finding a mutation, then genetic testing is recommended per NCCN. If the estimate is at 2.5% or greater, then it can be considered. And for example, we also use the NCCN guidelines to guide when it's appropriate to offer genetic testing. Now here we are, the end of April, and yet, as you know, NCCN guidelines are changing their guidelines multiple times per year. We're already on version 3 of 2025 for hereditary renal cell cancer. And so depending on whether or not that person is 6 years of age or younger with their diagnosis, if they have bilateral or multifocal tumors, or if they also, in addition to their diagnosis, have a first or second degree relative with renal cancer, that would meet NCCN guidelines. And then if there's a certain histology to the tumor diagnosis, or if there's some other combination of family history. And this is where I think it becomes difficult for the busy clinician. One, the guidelines are changing all the time. Are you pulling out those guidelines as you're eliciting the family history in the clinic to determine whether that patient needs a referral? Honestly, I hope to illustrate by the end of my presentation, these guidelines, at least for who should get access to genetic testing, should be thrown out the window, and I think we should be offering germline genetic testing to every patient with a solid tumor diagnosis. I think it's coming. I think it's going to be down the pike. We also discuss with patients, we help them anticipate what the possible test results are, that we could find a mutation or what the lab classifies as pathogenic or likely pathogenic and has the potential to impact medical management. We could get a completely normal or negative test result, in which case medical management would be based on the personal and family history that exists today. And then no one is prepared unless we share with them the possibility that we can get some gray answers, what the lab calls a variant of uncertain significance, or a VUS. So these are simply spelling changes in the genes, which are quite common, maybe 25 to 35% of the time, where the laboratory isn't willing to call it one way or the other, and so they call it out on the fence as a variant that they don't know what it means, if anything. And it's very important to appreciate that these VUSs do not impact medical management. There are way too many reports out there in the literature of people making irreversible decisions hinged on a VUS result that ultimately is downgraded to benign. We also discuss what federal protections we have against genetic discrimination. And fortunately, in the years that have passed, we have a number of federal laws to protect not only our health insurance, but also our employment. And we're well familiar with many of these, like HIPAA, the Affordable Care Act, the Americans with Disabilities Act. Not as many people, though, have heard about the Genetic Information Non-Discrimination Act. But I can tell you, it usually comes as a surprise when we tell patients during the counseling session that in most states, and where I practice in Pennsylvania, that we do not have any state law to protect against genetic discrimination when it comes to life insurance, long-term care, and disability insurance. Florida is one exception to the rule. And I do believe that there is another state that is considering implementing legislation to protect those other forms of insurance as well. And that gives them pause sometimes. I explained to them that they could certainly get all the no questions asked life insurance as part of their benefits package at work, but if they wanted to go out and get a private policy, or even if their relatives wanted to go out and get a private policy, usually you're presented with an application, and whatever questions they ask need to be answered honestly. So once those required elements of pre-test genetic counseling have been accomplished, we can then move on to whether or not the patient wants to move forward with genetic testing. And so to do that, we need to look at the patient in front of us. What type of cancer do they have? What genes do they need analyzed? What type of insurance do they have? Knowing these different laboratories and their different policies, we then pick a lab that is going to give us the information we need with the least out-of-pocket expense for the patient. And so we take into account their insurance, whether or not they have any insurance. We take into account the various patient assistance programs that these laboratories have. Some of them have very affordable self-pay options, as low as $249. We also develop an appreciation for what the turnaround time is for these laboratories. So if we're ordering a stat test, one lab may be able to get me those results in 5 to 7 days, where another lab is 10 to 12 days. So depending on when that surgery is scheduled, that might shift the sample to go to one lab versus the other. Some of these labs do offer that free reflex testing, one that I know of for 3 months, another for 5 months, to allow more of the family members to take advantage of free, well, the free cascade testing is a separate, but the free reflex testing, so that they can bump up to a larger number of genes. And then some of the labs also offer the free cascade testing for the family members at risk. And typically, we would have a follow-up appointment to disclose those results. But as the expanding indications were generating more referrals, admittedly years ago, we eliminated that return appointment and simply called the results out over the phone so that we could accommodate all the new referrals. And then offered return appointments specifically to those patients who tested positive. If we did find a mutation, we can utilize a number of different tools to illustrate to that patient what the likelihood of different cancers are by plugging in this example, that we're working with a male who's 25 years old. He was identified to have an MSH2 variant, diagnostic for Lynch syndrome, and then it illustrates for him what his lifetime risk is for these different cancers in blue in comparison to the general population risk in green. A more recent tool is MyLynch, which is a patient-facing clinical decision support tool where patients can learn not only what their lifetime risk for these various cancers would be, but then they can see what the impact would be of various management strategies. If they choose prophylactic surgery to remove the uterus and ovaries, if they take aspirin as chemoprevention for colorectal cancer, if they add colonoscopies every 1 to 3 years as part of their management strategy. And it can help them then make decisions about how their management should move forward in conjunction with their healthcare provider. We then also can make available to patients various research opportunities, such as the PROMPT study and the Inherited Cancer Registry, and put them in touch with different support resources. This FORCE organization used to focus specifically on hereditary breast and ovarian cancer due to a BRCA1 mutation, but it has now expanded so that it supports families with all different types of hereditary cancer. So these next generation sequencing panels, they have many good attributes. They help us analyze multiple cancer susceptibility genes at the same time in a more cost-efficient manner, and I've found from experience that they give us the opportunity to identify more than one genetic predisposition in the family if more than one exists within the family. When I was doing the traditional approach, if we found a mutation, we patted ourselves on the back, we felt we had done our job well, and what we've come to learn is that, there are many families that have more than one genetic predisposition to cancer. So take this family, for example. This proband, and I'm going to have to look real close here, he was diagnosed with a urothelial cancer. And you can see that there's cancer history on both mom and dad's side of the family. And so for him, even though we know that his mother's side of the family met criteria to offer genetic testing for Lynch syndrome, we offered him an entire panel of genes. Ultimately, he was found to have a deletion in EpCAM, which is upstream of MSH2, and actually the deletion continued into the MSH2 gene, confirming his diagnosis of Lynch syndrome. I then met with his brother, who was diagnosed with a renal cancer, but it was a clear cell renal cancer with sarcomatoid features, not a classic Lynch-associated cancer. Now, typically, when we find a mutation in a family, we do single site or single gene testing for that mutation only. But in this family, I told the brother that because he did not have a classic cancer associated with Lynch syndrome, that I would prefer to bump up to a panel. We would forego the free cascade testing, and we would bump up to a larger panel to address the type of kidney cancer that he was diagnosed with. And as it turns out, he did not have Lynch syndrome. Even though he had a 50-50 chance, because his brother was Lynch positive, he ultimately did not test positive, but instead he was found to have a mutation in the CHEK2 gene to explain his diagnosis. And we did subsequent testing in the family, ultimately finding out that the mother those two mutations passed both through the maternal side of the family. Interestingly, there was a paper out of Sloan Kettering by Dr. Carlo et al., and they looked at 250 plus patients with late stage renal cancer and found that 16% of them were mutation positive. Now, admittedly, only a third of those mutations that were found were in genes that were known to predispose to renal cell carcinoma, ones that you're familiar with, like fumarate hydratase gene, BAP1, VHL, the MET proto-oncogene, the succinate dehydrogenase genes. So obviously these other mutations that were found, we either don't appreciate all the genes that predispose to renal cancer, or maybe they actually weren't the cause of that person's diagnosis of renal cancer. But interestingly, of the genes that mutations were found in, CHEK2 and FH were at the top of the list. So in this family, at our hospital and many institutions across the country, we have a universal screening policy for Lynch syndrome because we came to appreciate that easily 95% of individuals in the United States are completely unaware that they have Lynch syndrome. And so since about 2010, more and more institutions have adopted this universal screening policy where any patient diagnosed with colorectal cancer or endometrial cancer, the tumor automatically undergoes either microsatellite instability testing or immunohistochemistry with the antibodies for the 4 mismatch repair genes. And so this patient's tumor did demonstrate absent MLH1 and PMS2 expression. Ordinarily, we would look for a BRAF mutation in that situation, and if found, it would suggest that it's a sporadic tumor and would not raise concern for Lynch syndrome. But in this patient, we did not find a BRAF mutation. She did move on for germline genetic testing, and initially she elected only to look at the 2 Lynch genes for which there was abnormal IHC, and that testing came back negative. We then reflexed to larger panels of genes, and ultimately she was found to have both an ATM and a BRCA2 mutation. Interestingly, although it was not known to the genetics team at the time, this patient had had tumor profiling, which clearly showed these 2 germline mutations present in the tumor. So anytime you are referring a patient based on tumor profiling results and there is a finding of concern, it's always best to indicate that that's the reason or one of the reasons why you're referring the patient so that we know to try to go hunt down that report. Now, despite all the good things that next-generation sequencing panels possess, there are also some not-so-good things. The more genes we look at, the more likely we're going to identify these variants of uncertain significance, and it's very important to prepare patients for that possibility. I strongly encourage patients, due to the fact that these are very common and the fact that most of them end up getting downgraded to normal over time, I just encourage them to let them roll off their back. In most cases, it's just signal noise, and reassure them that eventually, when the lab figures it out, they'll issue an updated report, and then we would reach out and let that person know the new interpretation. The other problem that we occasionally encounter is when we get a report from a laboratory that classifies the variant as a variant of uncertain significance. But when you go into ClinVar, which is an international database to see how all these other labs classify the variants, we find that maybe 1 or 2 or even 3 other labs feel that it is likely pathogenic or pathogenic. And in that situation, we want to disclose that discrepancy to the patient. If they want an actionable test result, I then encourage them to send a new sample to a lab so that we can get a positive test result, and then we can proceed to offering cascade testing to relatives at risk. And that's basically the situation that happened here. This actually was a very frustrating situation because I saw this patient all the way back in 2012, and she had a clinical diagnosis of von Hippel-Lindau syndrome. And I sent her sample to a lab for traditional Sanger sequencing at the time. It was before the panels came out in 2012. And she was found to have a VHL variant, but they classified it as a VUS, so an uncertain significance, but likely pathogenic. So they just weren't really willing to say either way. 10 years later, she was referred back to me because of a new diagnosis of breast cancer, and I then sent panel testing to a different lab that came back with a VUS result for that VHL variant. Now, the purpose of the testing was for breast cancer. And so I didn't give that lab all the information about, her features that were characteristic of VHL. And when I then, on the back end, provided the lab with the phenotypic information, they then upgraded the variant to likely pathogenic. But at the same time, I had asked the original lab from 10 years ago to give me their current interpretation, and they upgraded, they downgraded the variant to a VUS. So this yo-yo back and forth and discrepancy with different laboratories really undermines our confidence about the ability of these labs to classify these variants. And sometimes people are making irreversible decisions. So I make it a habit to always check ClinVar for any variant that is found so that I know whether all these labs are on the same page or not, and I disclose that to the patients so that they have more information upon which to make some medical decisions. Clinically, though, she should continue to be followed based on her diagnosis of VHL. We also could find mutations in genes where the cancer risks may not be fully understood. We might not understand the full spectrum of cancers. Is ovarian cancer part of this condition or not? I mean, I remember some years ago for NBN, which is a prostate cancer susceptibility gene, we also counseled females about an increased risk for breast cancer. And then a couple years later, we got notification, oh no, contact all those females. Tell them no, there's no increased risk for breast cancer. So that can be frustrating. And then the management guidelines are not well developed. Not all these patients want to go on that learning curve with us. And so some patients may only choose a smaller panel for which we already have management guidelines developed. We also can get some unexpected findings that don't match the family history at all. We can find a CDH1 mutation for hereditary diffuse gastric cancer where typically we've recommended prophylactic gastrectomy as early as 18 years of age. It's a little bit difficult to make that decision from a patient perspective if you have no family history of gastric cancer, if you haven't seen a family member die from an early onset gastric cancer. And then there's the secondary findings. The purpose of this testing is to find individuals that have a cancer susceptibility. It's not to find carriers of a condition like progeria, which happens. And because of that, some of these laboratories have actually removed a lot of those genes that would find carriers for different conditions, but not increase their risk for cancer. So one lab initially had an 84 gene panel. They've removed all those genes that would find carriers, and now they're down to 70 genes. Sometimes these panels can identify a mutation in a gene for which the cancer spectrum is not yet well defined. And in this family, we found an ATM mutation, but honestly, I can't say whether that's the cause of the renal cancer because that's just not been appreciated yet at this point in time. And I think in the interest of time, I'm going to move forward. I do want to mention that sometimes things can be pretty ugly with these panels. I unfortunately have been in a situation 3 times where a likely pathogenic variant was found. Patients made irreversible decisions, 2 to remove their ovaries and tubes, 1 to remove their breasts, and then a year or 2 later down the road received a downgrade to a variant of uncertain significance. And those are calls that I do not enjoy making. In each of those cases, I was fortunate that they were still very satisfied with their decision, and so it was not a problem, but this just illustrates the sequencing is the easy part of this process. The interpretation is the art and science of this process. So a recent study found that about 1 in 8 solid tumors across a variety of tumors are found to have a hereditary predisposition, a mutation in one of these cancer susceptibility genes. And interestingly, 48% of the patients would not have met NCCN guidelines to offer testing for susceptibility genes. And so it tells you that the NCCN guidelines, despite the fact that they're updated quite frequently, they've been expanding to include some universal testing for ovarian cancer, universal testing for pancreatic cancer, and so forth, universal testing for PGLs and FEOs. Not quite yet universal testing for prostate cancer, although I think it should be. But it just goes to show we're just scratching the tip of the iceberg here. And we're spinning wheels trying to find people with a hereditary predisposition using guidelines that are missing a significant portion of people. And when you see that nearly 1/3 of those patients that had a mutation in a high susceptibility gene had a change in management, whether it be surgery, chemo, or immunotherapy, or access to a clinical trial, we're not doing our patients the best service by using limiting guidelines to determine who should get access to genetic testing. And so as those expanding criteria continue to expand, we're going to have to think of some other measures. There's just not enough genetics providers to do all of this on the front end, the traditional approach that I laid out for you. So yes, we're going to have other medical professionals, whether it's a genetic counseling assistant, come into your clinic, or whether you're going to have one of your medical assistants, your PAs, your nurse practitioners. It's going to hand the patient a brochure, a video, or have the patient interact with a chat bot, and then order a one-size-fits-all panel to cover all the family history that they didn't take the time to elicit, because that's just not part of the upfront when you're doing it point of care. And then we can be involved on the back end. So in summary, although the majority of cancer is still considered to be sporadic, a growing number of cancers have been identified to be hereditary using multi-gene panel tests. Indications for cancer genetic testing continue to expand, and I believe will soon give way to universal germline testing. And so we do need to develop alternative service delivery models which leverage the time of the genetics providers and may help to address the growing access issues regarding these services. Thank you.
Great overview, and I think answers a lot of the questions that you may have. Oh, thanks. So if we can go to the next set of slides. You need me to do that here? I can pull it up. All right. So yeah, hi, my name's Jonathan Coleman. I'm from Memorial Sloan Kettering. I am not Brian Schuch, so I'm sorry if you're disappointed. Brian's a good friend. Unfortunately, he's under the weather and couldn't make it, so I'm going to be presenting his slides for him. So I apologize. This is what the slides that I was given. We are not in San Antonio, as you know. We are in Vegas, so hopefully you guys have had a good time. So I'm going to talk about the adrenal and renal genetic risk assessment, and I think just to, I'll use this here. Okay. So there were a couple pretest questions. I'm going to kind of skip past these really quickly because I don't think they're all that relevant. So as far as the genetic risk assessment for adrenal, let's talk specifically about adrenal. And as a pretext to the whole conversation, I just say that what you just heard should sort of send chills down your spine, because we're now talking about universal testing, okay, germline testing that may be coming down the line. So the fact that you're all here, you're getting inside information that many of your colleagues are not getting. I'm seeing Bob Smith in the audience. Bob and I both work at Sloan Kettering together. We do a lot of genetic testing at MSK, and I will tell you, it is scary what you find, because you start sending out testing, they find these variants of uncertain significance, they're calling you back, patients are confused, what does this all mean? You know, what am I going to do with this? And as a clinician, you're so busy already trying to just fill out your EPIC paperwork and everything else, you're like, I don't know how to handle all of this, and you rely on your genetic counselors to sort of take the reins, call their patients, talk to them about the significance of the testing that was done, screen all of their family members, and suddenly their family members are coming to see you, and now you're screening them for all these different cancers. So this is something that is really, really important for you to understand. And I think, you know, I'm surprised there aren't more people here, because you will see that this is going to become, you know, coming down the line, and it's going to be affecting you dramatically. And you're already very busy, and this is stuff that's going to be extremely significant. So adrenals, we all don't see a lot of adrenals in urology anymore. It used to be our field, and I think a lot of the endocrine surgeons have taken this over, but just being aware, just a quick overview of adrenal tumors. Chromaffin tumors, or the ones of chromaffin origin, are the pheochromocytomas. Those are the also paragangliomas. So paragangliomas are essentially extra adrenal pheos. That means they're just pheos in some other part of the body, just not in the adrenal. And then there are the cortical tumors, adrenocortical cancers. Those are the really bad tumors that send shivers down our spine when we hear about it. You know, that mass growing next to the kidney, and you think, oh, is this a kidney cancer or is this a big adrenal tumor? And these are the ones that you don't want to find in your practice. And then there's the benign tumors, the adrenocortical tumors, which many times are benign adenomas, but sometimes they're functional. So they can be cortisol secreting or aldosterone secreting, and sometimes we see these in our practice as well. But just keep in mind that's what the nomenclature is all about, we'll be talking about. So pheos. Pheos are very rare, so less than 2,000 cases per year in the United States. Put that into context of things like cases for testicular cancer. Maybe some of you guys maybe only see 3, 4, 5 cases of testicular cancer in a career. You're going to see even less of these. There's about 8 to 10,000 cases of testicular cancer in the U.S. This is magnitude less than that. So when you see these patients, realize that these tumors are often associated with a hereditary risk factor. All of these patients really should be tested. So the bottom line take-home message here is that for these tumors, when you see patients come in your office with a pheochromocytoma or a paraganglioma, you need to be sending them for genetic testing automatically. There shouldn't be any question about it. You tell them you got a pheo, you got a paraganglioma, I'm going to send you to see a genetic counselor, bottom line. What are paragangliomas? Paragangliomas can be anywhere from in the head and neck area all the way down to the pelvis. And some of us will see these patients because they have hematuria, because the tumors are next to the bladder or in the bladder, or patients have this Micturition syncope syndrome that occurs as their bladder starts to fill up or as their bladder starts to squeeze. The pheo suddenly becomes activated, and they develop paroxysmal hypertension. You may see them in your office because someone sends them to you because they have a bladder mass, and inside the bladder you find a pheochromocytoma. So again, these are syndromes that these are tumors that are often syndromic. In fact, many times or most of the time syndromic, and all these patients should be sent for testing, bottom line. Now, I hate putting up slides like this because everyone looks at this and like, I don't want to memorize this stuff or know anything about it. But the bottom line is that, oh, I got to go back. This went back. Okay, so, but there are a number of different mutations in like the RET gene. Has anyone heard of MEN2? MEN2 disease, okay. So MEN2 is RET, VHL, I think we all know really well. SDH mutations, all of these are mutations that affect different pathways in cell metabolism or in different hypoxia-inducible factors. And for some reason, why do you get a germline mutation? This is the weird thing that I keeps me up at night. Why do patients get mutations in these particular genes, and yet the only cancers they get are in the adrenal and in some cases in the kidney? Why aren't they getting other cancers? In some cases, we do see things like skin cancers or other locations, but why just in these locations? So I think it's still an unanswered question in terms of why it occurs in these areas. As far as the syndromes involved with these are ones, again, you should all be aware of. So VHL syndrome, retinal hemangiomas, CNS lesions, we'll talk more about this later, but neuroendocrine tumors, endolymphatic sac tumors, adrenal tumors, very common. NF, so this is neurofibromatosis, this is cutaneous neurofibromas and peripheral nerve tumors, as well as adrenal tumors. MEN2, we talked about medullary thyroid cancers, this is the RET gene. You don't need to memorize these, but just know that all these things can be present. And if you see patients who come in, who someone has a history of, say, a GIST tumor, a gastrointestinal stromal tumor, I will tell you about this, because this is probably the one place we'll talk about SDH mutations, but these GIST tumors involved with SDH, these are horrible cancers. They do not respond to Gleevec. Everyone thinks about GIST tumors. They're like, oh, I can give Gleevec, it's going to make it melt away. That's the new therapy. These are not responsive to c-KIT. These are driven by SDH. These tumors grow very aggressively. So if you find a patient with these syndromes, you're going to save not only their life potentially, but also the lives of their family members. So incredibly important for you to look for these syndromes in your patients. And then adrenocortical carcinoma, again, extremely rare, less than 500 cases in the US per year. You're not going to see a lot of these in your career, but if you do see them, they all should go for genetic testing, especially those that are found in children. And I'll go over that in just a minute. But the prognosis, as we all know, 20% 5-year survival rate. That's an 80% 5-year mortality rate. So imagine if you were to find a patient who had a syndromic cause for adrenocortical carcinoma, early identification could potentially save lives here. So hugely important. So children diagnosed with adrenocortical carcinomas should all be sent. Why? Because many of them will have Li-Fraumeni syndrome or Beckwith-Wiedemann syndrome. This is pretty obvious, though. You'll see it with hemihyperplasia and also other manifestations. So in children, there's small populations, or in children, it can be a problem. But also notable is that in this population, a specific population in Brazilians have this really rare variant of a TP53 mutation, and I'll go over that in just a minute, but these patients their tumors are driven by this one specific mutation, and it's at a very high prevalence in one area of Brazil. And so many people are now advocating that all patients with adrenocortical carcinomas should also be sent. Again, it's only 500 patients a year in the US, so it's not that big a deal, but the reality is that if you find it and you find a mutation in the family members, it can be significant. This is that Brazilian mutation I was talking about, found particularly in high prevalence in one small area, Brazil. Brazil is a huge country. Just down in this area, there's this one variant which is present. And it turns out that only this 0.3% of the entire population of southern Brazil, but for people who have this, adrenocortical carcinomas with penetrance is as high as, or has a high penetrance as high as 40% or 4% of kids before they reach the age of 12 years old. So they're actually talking about screening at birth for all people in this region of Brazil because of this risk. So this is sort of a new thing also coming out, things to be aware of. This is just all the different mutations we talked about. And then one more, hopefully you'll take home like one new message from this, and that is this recently described mutation in CDKN1B. This is MEN4. Who ever heard of MEN4 before? You guys have heard of MEN4? New syndrome just described 2 years ago. So a new mutation found that predisposes patients to adrenocortical tumors, parathyroid, pituitary, and those tumors are cortisol-secreting tumors. So let's talk about hereditary kidney cancer. So we just heard a lot about hereditary kidney cancer. It is probably one of the most prevalent types of cancer that in the urologic world that we see in terms of hereditary basis for tumors. Everyone knows about VHL. There's HLRCC, fumarate hydratase with mutations. There's folliculin for BHD and so forth. But you're going to see a lot of these in your patient populations that you may not even recognize. But what's really, really important to know on top of this is why is it so important to find these patients, not just so you can screen their family members and help to identify those tumors, but there are specific treatment pathways designed for hereditary kidney cancer patients and how we manage them. I'll talk about that a little bit later, but that's probably the most important thing that you need to think about is if you see a patient that you think has hereditary cancer, it's important to try and identify what that is because it will change how you manage them. You don't need to take out their entire kidney if they have multifocal tumors. You may have other strategies that can be used here. So this is a great thing. So most of these tumors are hiding right in plain view. I have patients who come to see me all the time, or I give talks about this all over the place, and I have someone come up to me and say, you know what, I did see a patient. I have a gynecologist who walked up one time and said, I have a family of patients who have these really horrible problems with menstrual bleeding. I've done hysterectomies on most of the family members, and one of them got this really aggressive kidney tumor. Do you think that could be hereditary? And I was like, you have a patient population that has an FH mutation. That's HLRCC. Those patients need to be screened. So again, they're hiding in plain view, and often because people think of things like, really bad menstrual cramps or menstrual bleeding as being something that's kind of common, or uterine fibroids as being common, and not necessarily associated with a cancer syndrome. In fact, it's right there, and sometimes your gynecology colleagues or other colleagues will show it to you. So where are we learning about some of these things with the WHO classification? So for those of us who work in the kidney cancer field, this is the morass that we deal with. These are all the types of cancers described by the WHO, so many of them. But there are some that are specific. Fumarate hydratase, this is HLRCC. Succinate dehydrogenase, we talked about this. This is HDH, also associated with kidney and PHEOs. Another one with kidney and PHEOs is what? Somebody tell me. Kidney cancer and pheochromocytomas. I talked about SDH, and what's the other famous one? VHL. Yep, so VHL. So these look very similar. You can't just do a VHL panel on a patient with a kidney and an adrenal. You also have to think about SDH. And then this, oncocytomas. We're now describing, there's been a number of presentations giving about renal oncocytomas or familial renal oncocytosis, huge problem that we're now seeing in the patient populations. For all the tumors that we know about, clear cell papillary, chromophobe, collecting duct, they all have associated genomic mutations associated with them. So you can't just look at the cancer type under the microscope and say, oh, this is what it is. However, we are finding that FH-related tumors, these that used to be called papillary type 2, we don't call them papillary type 2 anymore. These are now called HLRCC tumors that they're now identifying. Our pathologists are identifying this all the time, and so when it happens, they're referring those patients to us, and now we're seeing them and we're screening them. So that's the reverse pathway coming from our pathologists, not just what we're identifying in the clinic, but what now the pathologists are identifying and telling us about. Here is sort of the slide of all the known genetic mutations, the VHL, CMET, which is for papillary renal cell carcinomas, HLRCC, BHD, and so forth, tuberous sclerosis. You've all seen these in your clinics, but how many times have you sent patients for genetic testing? The more you know about these, the more you send them. In my clinic, I'm sending patients all the time. I have patients that are constantly, they're young, they have family members and so forth that have other cancers. And then there's the unknown unknowns. We heard about this just a minute ago, but it's a question of, someone comes in, it runs in their family, we test them, the test is negative, we tell them you don't have it, but the reality is our testing just isn't good enough to find it now. It may find it better in the future, but for those patients, how do you treat them? Does anyone ever have a patient that they sent off, they thought they had genetically inherited cancer, and it came back negative? Anybody? And what do you do with them? What do you do? Tell them they don't have it and send them away? You tell them what? Who should follow up? Huh? That's the best I can do, but what do you say about, you say, we couldn't find it, but then they'll ask you, do I have it? And then you say, maybe. And then you say, well, what should I tell my kids? And what do you tell them? What about their kids? When they ask you about their children, when they say, well, I got all these kids, you say, you don't know. It's a difficult question. It's a very difficult question, right? So what I end up doing is I tell them, you know what, I don't know what it is, but the reality is there's something going on here. Your mom had it, your grandfather had it, you have it, we can't find it, but there's something here. And unfortunately in those patients, because we don't have a genetic test, what we end up doing is we end up just screening all the family members. We just tell them, you know what, I tell them, you know what, just tell your kids, maybe when they reach age 30 or 40, they probably should get an ultrasound. And you'll be surprised how many of those patients go home, they have their brothers and sisters get tested, and suddenly their brother calls you and say, I've got a tumor as well. And you're like, okay, there's definitely something going on here. So simple testing like just ultrasounds and so forth can be offered. And at our center, for a patient who's got a phenotype and has the family history, but we don't find it, we actually get ultrasounds on the family members once they get over age 30 or age 40. This was gone over before already, but this issue of germline carrier mutations of unknown significance. So there are a lot more patients who walk around with these mutations. We just don't know about them. This is the same for folliculin, again, an unknown significance, but up to 11% of patients may have some mutation in folliculin, but they don't have the manifestation. So these genetically inherited syndromes are probably much more common than we know of. And it may be that it just comes, they're autosomal recessive. So we have two people that get married, they both carry the gene, and suddenly their kids may have it. So these are things that are popping up now more and more often. This again was gone over before, but there are some new mutations we're seeing. So the CHEK2 mutations, ATM mutations. I'm seeing a lot more of these in my clinic now because now we're testing and screening for patients, and we're finding a lot more of these patients where this runs, and we don't know what the significance of it is. But we will say in our group, we looked at it specifically in advanced renal cell carcinoma, and the take-home message we would have from our group is to say for patients with advanced renal cell carcinoma particularly, it's a little bit enriched in this population. So that's something you need to think about for patients with more advanced cancers. And when we looked at it, so these are the known cancers that we knew about, but when we looked at an expanded set, we saw that there were more. This is a big UK cohort they looked at for a group of 1,300 patients and did whole genome sequencing. In these patients, they found about a 4.5%. Again, these variants of unknown significance were found. So these are out there. You just aren't seeing them because you're not particularly noticing them. I'd say the red flags, and this is sort of the take-home slide. So if you're going to photograph anything, this is what you want to photograph, but it's this one. So patients who are young definitely have a higher risk. Bilateral tumors, multifocal renal cell carcinoma is a very strong family history of kidney cancer, especially in more than two relatives in the same bloodline. renal cell carcinoma, the personal family history of more than one tumor type, skin conditions, family history of kidney cancer syndromes. These are the things that you just need to ask about. And you know what the reality is? We all do a really bad job of this. We don't ask very much. And there's multiple papers showing that, that we miss roughly about 50% of patients by trying to ask these questions, because patients in the office don't often know what's going on. They don't know their family history. Suddenly you get genetic testing and things are showing up. The guidelines we talked about, they're highly varied. It drives me crazy, this number of age of, have to be less than age 45. I have like a 48-year-old guy comes to my office and he's got an 8-center renal mass, and I can't genetically test him because he's over the age of 46. And I say, you had this tumor when you were 40. You know, this has been there for a long time. You don't get an 8-centimeter tumor overnight. But an age cutoff, I think it kind of is misleading. And then as far as the hereditary kidney cancer guidelines, it just walks you through. So if you have a patient, you have to risk assess them. If they have a known familial variant, then you recommend testing and so forth. And then these unknown familial pathogenic variants, and then consider, sort of more broad testing. I would say, as was already mentioned, that we're getting away from this targeted testing, because this targeted testing is often missing things like if we're not looking more broadly. So as it gets cheaper and easier down the road for us to do this type of germline testing, you're going to see a lot more of it. Let's talk briefly about the medical management of VHL. As you all know, it's rare. Maybe you've seen one or two patients. Anyone seen a VHL patient here? Good. So, and family members and everybody comes in. What we all know about this is that it's used to be that these patients would die of kidney cancer at a very young age. Now they're living into their 60s, and now they're suffering from the other manifestations of the disease, the ocular hemangiomas, the CNS lesions, the ataxias and other things. So this can be a very highly morbid disease. This is holy grail is medical management. This came from Brian. I would sort of argue about this a little bit, and I would say, I'm not sure that medical management is the holy grail. Obviously, I think what we all want to do is do the least invasive, less toxic things to handle our patients. We have, great therapies that can maybe handle, things like genomic alterations, maybe some of the downstream effects of it. But, we right now have a lot of toxicities associated with the medical management for this disease. So I think, certainly coming up with a better approach that's less toxic to our patients is important. You guys know about this. This is the brainstem lesions that they have, the cerebellum, the retinal lesions, the spinal cord lesions. This is the morbidity of this disease. My wife's an ophthalmologist. She handles all the ophthalmic findings from VHL. These patients go blind at a young age. They're trying to keep their eyes just for cosmesis so that they have two eyes in their head and they're not walking around with something like a glass eye or a prosthetic. So that's a big problem for these patients over time. Renal cell carcinoma is the #1 cancer, pheochromocytomas. Pancreatic neuroendocrine tumors, typically low risk, and then the endolymphatic sac tumors, which can cause some hearing loss. Then everyone talks about this CHUVASH mutation. This is a little bit weird because these patients don't have, this comes from the CHUVASH region of Russia. It's a very rare mutation. You probably won't see it much in your career because it only causes polycythemia. But in some cases, where polycythemia is pretty rare by itself, but if patients have polycythemia, they go for genetic testing anyway, and sometimes they'll find this rare mutation in VHL, but it has no kidney manifestations, no PHEOs, none of the other stuff. It's just purely polycythemias. As far as the screening guidelines and looking at things like VHL, this the important thing to know, as we talked about, if you find these patients with VHL, HPRC, hereditary papillary, BHD, or chromosome 3 translocation tumors, there's a very different pathway of management. We don't go in and operate on these patients right away for their kidney tumors. If they have VHL or any of these other ones I just described, we use the 3-centimeter rule. So we watch these tumors until the largest one reaches 3 centimeters, and then we operate. Otherwise, we'd be operating all the time on these patients. We don't take their kidneys out because we don't need to. We can do kidney-sparing surgery or kidney-sparing approaches, and we can do that over time without the need to be aggressive surgically. So finding these patients is incredibly important and will change the pathway of management for them. I just put this up. I don't want you guys to really know about VHL and how it regulates HIF too much, other than to know that VHL works together with HIF to basically sequester HIF so it doesn't work. HIF is hypoxia-inducible factor, so it is the main driver of things that occur when VHL is mutated. When VHL is mutated, then there's no longer any regulation of HIF. HIF just goes off, and TGF-alpha, GLUT1, all these other things
tumors, start to grow, you get invasion, you get overproliferation. This is where, things go awry when VHL is mutated. So it's not the VHL that's causing the problem, it's the downstream part, which is HIF. The reason why this is important is because if you go back in time and say, when VHL was first discovered, how important of a discovery was that? It was huge because it led to all of our understanding of the downstream aspects of VEGF signaling and all the different aspects of sporadic kidney cancer that we know that over 95% of sporadic clear cells have a mutation in VHL. And that's where the entire TKI era of management came from, was the understanding of VHL and HIF. We're now much more targeted even more parts of the pathway. So mTOR inhibition, PI3 kinase inhibition, and different aspects of HIF translocation that we've been looking at, or translation that we've been looking at as far as ways of targeting this area, this pathway. These are all the trials that we've tried to run over the years in patients with VHL. None of them were effective until we got to this, specifically a HIF-2 alpha inhibitor. There was some data in sunitinib, and I'll show that in just a minute, but in this trial, first-line agent sunitinib in patients specifically with VHL, about a 64% response rate overall. So this was the therapy of choice for a long time in patients with VHL when these patients develop metastatic disease. Then along came belzutifan. So Eric Jonash ran this trial with a large group of investigators showing that with an agent that specifically targets HIF-2, or HIF-2 alpha specifically, that not only do you get a regression, so this is the growth rate of these tumors up to 3 centimeters, you treat them, and then the majority of these tumors will respond, not just in the kidney, but also in the eyes, in the pancreas, in the brain. So belzutifan is now a therapy FDA approved for the treatment of patients with VHL. So again, incredibly important to find these patients and then shuttle them towards your medical oncologist to talk about the use of belzutifan therapies. This is just an update sort of showing some of the growth charts. So there's been a little bit of a difference in terms of the response rate. So now there's been a 3% reported complete response rate in patients. Not great, but better than nothing. And they're very strong partial response rates being seen in clear cell and then in pancreatic neuroendocrine tumors and in CNS as well. These are the side effects. We talked about side effects before. We all know there are side effects to medical therapies, the main one being anemia. So a large portion of these patients will develop anemia of any grade, and in some cases, severe. These patients need blood transfusions. So it's a great therapy, but a lot of side effects. Fatigue, headaches, dizziness, and nausea, again, other issues that patients deal with. But then you're also reminded of this story. Does everyone remember the mTOR inhibitor story for TSC? Does anyone give mTOR inhibitors to their patients with TSC angiomyolipomas? So what happens when you give it? So number one, it's a teratogen, right? So it causes teratogenic effects for children. So women of childbearing age can't take it, and yet that's a lot of the patients who suffer from this. The other is when you stop it, the tumors grow right back. And in fact, they may even grow back at a faster rate. So how do we manage this, going forward when we have a great drug like belzutifan and we think about sequencing their therapy? And I think that's where we are today in this aspect of pathway targeted era. So we want to optimize the management strategy we have for VHL tumors, but if you were a patient with VHL and you had 3 tumors in your kidney and maybe you had a small pheo and you're watching these tumors get to 3 centimeters and they say, oh, now it's 3 centimeters, we're going to put you on belzutifan. And when knowing all the side effects and all the symptoms and other things that are there, you're like, well, I don't have any CNS lesions, I don't have anything else going on. Couldn't you just take these tumors out of my kidney and I can just forego all these other side effects? And I think that's the discussion right now is, how do we sequence this? Also, once you've shot your shot, once you've used your belzutifan, the tumors shrink, then they start to grow back. What's left? What do you use later down the road when you've got resistance? And now we're seeing a lot of patients coming into the office and in the clinic who've been on belzutifan, tumors shrank for a couple of years, now they're coming back. And now we have to treat those, with surgery. Surgery can be a little more difficult. These patients have chronic anemia, other, side effects and factors going on. And then what do we do? Do we keep them on belzutifan afterwards? So I think right now we're in that era of trying to figure this out. And this was a nice paper that Brian put together, just simply looking at sort of this aspect of how urology specialists and medical oncology specialists think about it. 71% felt that MedOnc is now going to be a lot more involved in these patients' care. Maybe will urologists be giving this drug? I don't know that many of us will because we're already pretty busy. But then as far as using continuous treatment until toxicity or failure to respond, this is a difficult thing, I think, for patients to deal with. And then the use of intermittent treatments and so forth. So I think, again, the field is still evolving in this era. I'll talk briefly about genetic testing guidelines. Actually, a lot of this was gone over already, so I don't think there's too much more I can add. But ASCO does consistently endorse the use of informed consent for germline testing. So this means that for your patients who send for germline testing, you need to obviously, they have to go through a process, as was just nicely described, in terms of how to provide genetic counseling. Can you do that in the office? No, you probably don't have the time to do it. But you need to be aware of it, and you just heard a lot about it, so at least that way you can talk to your patients about it so that they can understand what to expect. As far as the testing itself, it's not just a blood test. It's not like getting back a creatinine and saying, well, this is your creatinine, this is your GFR, or this is your risk for heart disease, looking at things like triglycerides and so forth. They have to be specifically counseled, talk about a comprehensive evaluation, get pre-test counseling, talk about the test selection, all the things we just talked about. But this part is also very important, explaining the outcomes. I know you guys don't have time to do that. In my practice, and Bob, the same thing. We don't have time to sit down and describe all these outcomes as you just heard to these patients. So, having a good relationship with your genetic counselors at your institution, or some place where you can reach out to a good genetic counselor, is really important. And this aspect of unexpected results also comes up. Sometimes patients will say, well, wait a minute, we were checking for my kidney cancer, and now you tell me I've got a BRCA2 mutation. I really didn't want to know that. Now I got to tell my family, that they're at risk for breast cancer. And I've had some really strange reactions from patients, by the way. Some of them say, well, I don't want anyone else to know. And you say, well, really? Like, you don't want your kids to know that, they might have a BRCA2 mutation? You don't want your daughters to know? And they're like, well, I don't want them to think that they got it from me. And so you're like, well, if I was your daughter, I'd be pretty upset, if I developed breast cancer and then I found out you didn't tell me, I was like, can you really have these conversations, in clinic? It's amazing, sometimes what you deal with. Maybe I'm in New York, you guys don't have the same thing where you are, but that's sometimes the responses that we get. But having a good genetics counselor to kind of talk them through that process and explain how this can be done, in a non-invasive way is important. There are challenges. I think you heard about this already, so I'm going to skip past this. And then this issue of telehealth adoption in genetic counseling, I think this is huge. So this is going to take a lot of this off of our plates. We do a lot of video and telehealth work at our place. Our genetic counselors will do this, by over the video lines, and it just saves a lot of time in terms of being able to do this with patients. And then there's a bunch of other testing companies that are now coming, into the era or into this arena that I think are going to help us because they'll take on some of this burden. Interestingly, I do genetic testing. I've been doing it for decades. And then the thing that was so disruptive to me that I couldn't quite fathom was 23andMe. 23andMe comes along and everyone's just like, I'm sitting there counseling patients forever to tell them about their risk. And then someone watches a commercial to figure out whether they have to wear lederhosen or a kilt, and they're sending off their genetic information and signing away everything. And I'm like, that's amazing to me. You just signed away your genetic data that's going to be given to third parties and other people, and you really didn't care, but yet we spend all this time. But these genetic testing companies can actually take that off your plate to some degree. They'll take on that liability to some degree. The question is how that's going to happen is going to be anybody's guess. It has to be very carefully thought out and very, and I think is best done obviously with medical, support and counseling on top of that. We talked a bit about this already. We talked about the group-based, the counselor-based, and provider-initiated aspects. And then the use of video. So again, this has been gone over already, so I can skip this. And then this is Brian's last slide where he's, essentially putting together this idea of having an identified patient, giving them through a flyer resource center, going through a coordinator, scheduling visits either in person or virtually, or even done at home. And now we do this not with a blood test, but with what we call a spit kit. We send out a saliva test, they get it in the mail, they spit into a Streck tube, they send it back, and we can run it off of that after they've done their video counseling. And we have a 5-minute video that patients watch before they do their genetic testing. It takes no time at all, so it's much more easy. So with that, I'm going to end and I'll hand things over. And if I have questions, I'll take them at the end and go from there. But thanks, and I'm just going to leave you the answers to your questions that we didn't give you, and then Brian Schuch's information, so call him, not me. No.
Okay, so close it out. Okay. I don't know about you all, but those two talks, my brain is hurting from the amount of information. The good news is, on the prostate side, there is much less known, so you can get a little bit of a mental break as I cover this topic. But still, there's a lot to talk about. I'm Minhaj Siddiqui. I'm from the University of Maryland. So I'm going to talk about prostate cancer. No applicable disclosures. This talk, it's broken up into 4 main areas. Who should get genomic profiling, which patients should undergo germline testing, and then how do we screen and treat these patients. So, I mean, it's really interesting as you go through the different diseases, and I think with prostate, one of the nuances that seems to be more important than maybe even some of the other diseases is this aspect of germline and somatic mutations. And so I want to just emphasize it for a second, right? And I'm sure you're aware of all this, but it's good to just remind. And so germline, does the pointer, oh, okay, there we go. If I do it that way, it works. So germline mutation, right, is a mutation in all of our cells. I know it's super basic, but again, it's a good reminder. And somatic mutation is a mutation in the tumor cell. And both are important when trying to understand the genetic basis of tumors, because many cancers are related from the germline versus others that have more mutations that arise within the cancer. Okay, these are hereditary, these are not. For germline testing, we do the saliva, the blood, buccal swab, whereas here you need tumor sample, right? And both guide treatment, both give you prognosis. And so these inherited syndromes, right, and the various kind of tests available in Vitae, Myriad, and whatnot, they give you the germline genetic sensitivity. And then within the tumor, there's the tumor-based testing platforms like Foundation, Caris. These give you different things sometimes, right? They're especially like microsatellite and tumor mutation burden. You're only going to get tumor mutation burden by definition from the tumor sample, not from a germline test. And so it's important to recognize that. And these can change too. As tumors evolve, these change. You're not changing your germline profile, you are changing your tumor profile. And that actually comes into play in some of the guidelines, especially the newer ASCO guidelines. It's worth recognizing, but we're not going to cover in this talk gene expression profiles, right? The Decipher Oncotype Polaris profiles, and so that exists and is very much being used in our field, but it's beyond the purview of today's talk. While this was demonstrated earlier too, most tumors are somatic variants, with a significant number being germline variants. That's funny. This is a very easy test. So, a 70-year-old man, metastatic prostate cancer, had a tumor sequence of metastatic retroperitoneal lymph node. The test shows BRCA pathogenic variant. Without knowing more, what's the best description? So, who thinks it's A? So, is it germline mutation? How many people think it's germline mutation? How about somatic mutation? Could be either. This mutation is both germline and somatic since it's found in the metastatic lesion. And it's this one. With susceptibility alleles, you have a range of different alleles, and they're characterized by either phenotypic effect size and population frequency. And so you have rare allele changes within populations that have high predisposition. And so these are not found that highly in the population. However, the relative risk of having a cancer with these changes is actually quite high, right? And then we have others where there's low penetrance, but they're common. And with these, often we want to use polygenic risk scores. Okay, some of the things that we're gonna really focus on are the ones that kind of fall over here with high relative risk. Who to test? So based on NCCN, there's actually varying kind of opinions out there right now. And so ASCO and NCCN have 2 guidelines out on who should be tested. Generally speaking, it's important that germline testing should be done in patients with metastatic prostate cancer. Now, depending on your practice, you may or may not be treating, but increasingly urologists are managing, especially with large urology group practices. And so this is very much, I mean, if you take a few things away from prostate cancer genetic testing, one is that everyone with metastatic prostate cancer and nodal positive disease should be getting germline testing. Also with the NCCN, it's recommended for localized high-risk disease and very high-risk disease. I'm going to kind of cover that in more detail. The patients with node positive and metastatic disease should also, in addition to their germline testing, be getting tumor somatic testing. Okay, so you want to get both. And with these, it's ideal to do it in the metastatic lesion, the kind of the most aggressive lesion. I'm going to show you why in a second. Also, for the germline testing part, patients with a strong family history, and I'll cover that in more detail in a second, are also indicated by NCCN for germline testing. Why do we want to make sure we try to get the metastatic site? Because there is tumor heterogeneity, right? And this is an important concept. And so you can have a tumor start off in the prostate, and this has been shown. This is like, I think, a very elegant study that I love to reference. And you know, what they did in this study is they sampled various tumor sites, both within the prostate and actually in a metastatic site. And there were sequential mutations that take place somatically within those tumors, and such that you see these kind of mutation trees of evolution. And the metastatic site has accumulation of various mutations that were not present necessarily in the primary tumor in the prostate. And so the hope is that when you sample and sequence a metastatic site, that you will capture some of the driving mutations that may not actually be well appreciated in a prostatectomy sample that is saved from a few years ago when the patient first presented with this disease. That's a key kind of differentiator. And that's rough because you already have tissue from prior surgery, and yet it's desirable to rebiopsy a metastatic site if possible. There's also ctDNA, but that can be a little bit tricky, and I think it's still an evolving space. It's also worth knowing that various genes have various degrees to which there's somatic variants versus germline variants. In some cases, the rate of germline variants is quite high, such as like PLB2 and MITF. With BRCA2, it's about 30%. Also, when you look at primary tumors versus metastatic sites, the percentage that are germline variants versus somatic variants varies. And so in metastatic sites, the somatic variant percentage is higher, whereas in primary tumors, often you'll see these be less. In terms of who should get germline testing in the localized setting, the high-risk patients, which are defined as one of these features, clinical T3A, grade group 4 or 5, PSA 20, or very high, which is T3B or 4, primary pattern 5, 2 to 3 high-risk features, greater than 4 cores. In terms of family history criteria, the family history criteria are Ashkenazi Jewish ancestry, known family history of familial cancer risk mutations, especially BRCA1, 2, ATM, PLB2, CHEK2, MLH1 or 2, MSH6, and PMSH2. Father or brother or multiple family members of prostate cancer, especially when they were diagnosed less than age 60, or had regional metastatic disease, died of prostate cancer. And lastly, greater than 3 cancers on the same size family, especially when diagnosed less than 50 years. And you know, I mean, look, there's a lot of different tumors out there, but you should probably have intake forms and dot phrases to help kind of organize this. That's one of the things you can do to kind of streamline this in your own practices. In terms of what test to order, there are a number of platforms out there. The main thing is just to, you know, and there's high variability on what they do and don't test. There is a panel of different genes that need to be assessed. And the main thing you want to make sure, if it's targeted for prostate, it's going to have these, but like you want to make sure it's capturing BRCA1, BRCA2, ATM, and whatnot as listed on the slide here. The BRCA2 is the most common prevalence in terms of germline mutations. This is just kind of overall about, I think one of the test questions had this. The different populations will show different prevalence from a localized cohort down, or general population cohort of 2.7% to a metastatic cohort of 17%. This is captured on this next slide a little better, or a little more easier to understand. So for patients that are just general population, proportion with pathologic germline variants is low. You enrich this when you check it in a metastatic, and that's why we want to check it in a metastatic population, because up to 12 to 17%, and this was one of the questions, by the way, but 12 to 70% of this population, metastatic population, will have a pathologic germline variant. This is the ASCO guideline that just came out. I think it came out in February of this year. It is slight variation from the NCCN guideline. The main thing is in terms of who should receive germline testing, the ASCO guideline mainly focuses on metastatic prostate cancer population, who should receive somatic testing, and it also focuses on the metastatic population who are being considered for biomarker-detected systemic treatment. And lastly, they add this piece: who should receive sequential. I don't think NCCN talks about this as explicitly, but the ASCO testing discusses how sequential, and with sequential, it's mainly somatic, right? As a reminder, because your germline is not changing, but sequentially your somatic test might. The panel recommends that sequential somatic testing may be offered when there has been meaningful change in the patient's status or treatment plan, especially in cases where prior tests were negative or uninformative. So that's an important thing to know, and is, I think, pretty helpful. Hereditary prostate cancer characteristics. So there's a higher risk of prostate cancer with BRCA1, 3.8-fold, and with BRCA2, 8.6-fold of getting high-risk prostate cancer. These patients get earlier onset prostate cancer, more aggressive phenotypes with a higher proportion of Gleason 8 cancers, higher stage disease, T3, and plus, and metastatic disease. And these patients have worse outcomes. Unfortunately, it's a tricky thing, because we know these patients do more poorly. We want to be more aggressive, but there's not a lot we can do beyond that right now. So what do we do when we know someone has, say, like a BRCA2 mutation? I think that, like, right now the recommendation is really to just be more aggressive about screening. Try to catch this disease earlier. Begin screening at age 40. Have a lower PSA cutoff, 3 rather than 4, and go from there. In terms of NCCN recommendations, it's really just kind of the same stuff that you would normally do, in terms of repeat PSA, DRE, check MRI, and work it up accordingly. These patients do more poorly, but we still just treat them as we know how to treat them. It's just worth knowing, and I think it's important for counseling to know that these patients will have a higher degree of upgrading at the time of and progression to metastatic disease. And definitive treatment surgery. These patients do have. Oh, I skipped ahead in my thought process, but the metastatic free survival and cancer-specific free survival after treatment is worse in these patients. So I think this is an evolving area, but I think right now there's still no definitive optimized way to treat these patients much differently in the localized setting. There's no guideline recommendation for management of localized prostate cancer in men with BRCA mutation, but close follow-up. And for patients with Gleason 6 cancer, it's still active surveillance, but again, more than will progress. So close follow-up is important. And the role of germline testing is still unclear. So how do we treat patients? Now I'm going to transition to advanced prostate cancer. And for this, there is actually some things we can do. So we're moving into an era of precision medicine where, based on some of the testing outcomes, we can actually personalize therapies. And this has been great because in prostate cancer, there's really been two kind of areas that have emerged. One is for the DNA repair genes, so BRCA1, 2, ATM, these are the most common ones, but also PLB2, CHEK2, PARP inhibitors. That's emerging as a useful thing. So olaparib, in particular, rucaparib. And then mismatch repair genes, microsatellite instability, and tumor mutation burden, pembro is being used. So I'm going to wrap it up there. Genetic and genomic profiling is the standard care in management of patients with prostate cancer, especially metastatic and advanced prostate cancer. Most important prostate receptor genes are, as we've been covering and just listed there. Patients across the spectrum of prostate cancer qualify for genetic evaluation. If you take anything away, if you're managing metastatic disease, and more urologists are, this should be part of your pathway. Okay, it's really important. And patients qualify for this. It's NCCN mandated, and it's NCCN recommended, and it is covered. Often, it takes a little work to figure it out, but for high-risk localized and node-positive metastatic disease. Precision therapies are now approved for cancer, especially the PARP inhibitors, and pembro for the, as I mentioned earlier. Okay, I'll hand it off to Dr. Trong at this point.
Okay, we are on to the last sessions here, and actually this is probably the area with the most development over the past couple of years. And actually, as of yesterday, we have a new development. We have a new study that was published in the New England Journal of Medicine that is going to, hopefully you find that very interesting and exciting. So this is the outline of my talk today. I will discuss about the role of genetic evaluation in urothelial cancer. This includes bladder and upper tract urothelial cancer, the impact of germline mutations, and explore how genetics is beginning to shape targeted therapy for these cancer types. So we will start with a case that we may see as a urologist. This is a real case. The patient is a 42-year-old woman presented with gross hematuria. She has a CT urogram that shows a 4-centimeter mass in the renal pelvis. She underwent a radical nephroureterectomy, and the pathology shows high-grade urothelial cancer. Now, most urologists may document that she has no history of family history of GU cancer, but having attended this course, to take a thorough family histories, and noted that her mom have a hysterectomy for unknown reasons, and she have also colon polyps. She had my maternal grandfather who died of colon cancer at the age of 49, and a maternal uncle who died from cancer of unknown origin. Now, it's important to talk in urothelial cancer about what different assays that you use for genetic testing, because they're not all the same. Tumor sequencing, as Dr. Siddiqui have noticed in his presentation, may pick up both somatic and germline variants. So it's important that when you send a tumor profiling, you should inform patients that there may be unexpected germline findings because of that. And some assays subtract the germline, so you get a true somatic mutations. But some assays, they will just give you all the mutation that's found. And one way to know that is that if you only send the tumor for sequencing, there's no way that they can subtract the germline unless, you send an assay where they ask you to submit both the tumor and a saliva, a buccal swab, a blood test to subtract the germline. Now, there's a way that you can potentially infer if a mutation found on tumor profiling is germline or somatic, and that is variant allele frequency. And some tests will give you that information. So what is variant allele frequency? That is the proportion of variant sequencing read within a specific genetic alteration. So if you imagine germline mutation, you have about 50% of those variants in in every cell of your body. So a variant, the higher the variant allele frequency, the higher the likelihood of it being germline, and that's how some tests can also flag down the potential germline mutation that you found. So here, on the first panel, the germline panel testing, pretty straightforward. You're looking for germline mutation. Tumor profiling, we talk about, you may pick up some germline, you may pick up mutation, you don't know, somatic mutation, you don't know. And then cell-free DNA is also interesting because you send the blood sample, but cell-free DNA can be germline or can be somatic, and you don't know that unless you submit a germline analysis. Now back to our case. So you send this patient, 42 years old, with upper tract cancer for genetic testing, and see, in fact, found to have an MSS2 pathogenic variant, which is associated with Lynch syndrome. So what is Lynch syndrome? This is where we're going to spend the majority of our time here for this part of the presentation. Lynch syndrome is by far the most common hereditary cancer syndrome seen in patients with upper tract and bladder cancer. It is autosomal dominant, meaning that you only need one copy of the gene to have the mutation, to have the syndrome. It's rarely de novo, unlike VHL. So about 10 to 20% of patients with VHL can have de novo mutation, meaning they didn't inherit it from their parents. It just developed when they was in embryos. But Lynch syndrome, you almost always have a family history. And it's caused by these 4 genes, MSS2, MSS6, PMS2, and MLH1. IPCAM doesn't really occur by itself. It typically occurs in combination with MSS2 mutation. And despite being a very rare cancer, upper tract cancer is rare. It is the 3rd most common cancer associated with Lynch syndrome after colorectal and endometrial cancer. So now if you see a patient with upper tract urothelial cancer, the question should not be if anyone in your family have GU cancer. You should really ask if anyone have colorectal, uterine cancer, their age of diagnosis. Similarly, if you see a patient with prostate cancer, you should be asking about breast and ovarian cancer in the family. You wouldn't ask for if anyone in your family have kidney cancer, because there's no syndrome that links kidney and prostate cancer, as far as we know. And Lynch syndrome have a very distinct tumor phenotype, which is MMR protein deficient and MSI high tumor. That is important in their management. This slide shows the cumulative cancer risk by genes up to the age of 80. So what I want you to take away from this slide is that the genes that are most often associated with upper tract cancer are MSS2 and MSS6. But MLH1 and PMS2, I have seen them in patients with upper tract cancer, but just much rare. When should we think about Lynch syndrome in our urothelial cancer patient? The 3 triggers include family history of early onset colorectal and endometrial cancer, a personal history of upper tract cancer combined with colon or endometrial cancer, and the most sensitive testing criteria are by tumor testing, which is mismatch repair deficient or microsatellite instability high tumor. And in fact, this is part of the AUA guideline. This is the AUA upper tract urothelial cancer guideline that say that every patient who have upper tract cancer, there should be universal histologic testing for by IHC or by next generation sequencing to look for patients with mismatch repair deficiency or microsatellite instability. And this is a strong recommendation. So why is it? Well, because studies have shown that patients with MSI high tumor and urothelial cancer is often associated with Lynch syndrome. This is a paper published out of Memorial Sloan Kettering in 2018, where they evaluated 1,000 patients who underwent MSI high testing for tumor, and they went back to everybody who have MSI high tumor and looked at their germline result. Okay, and here they asked if you have bladder or upper tract cancer and they have MSI high, what are the chances that you have Lynch syndrome? And the answer is 38%. And this is much higher than actually compared to colorectal cancer. So if you have MSI high colorectal cancer, the chance of you having Lynch syndrome is only 19%. And then if you have MSI high endometrial cancer, your chance of having Lynch syndrome is only about 6%. But if you have upper tract urothelial cancer and you have MSI high tumor, you have a 38% chance of carrying Lynch syndrome. So this is a series from MD Anderson showing the results of universal tumor testing in patients with upper tract cancer for Lynch syndrome. As a baseline reference, there's about 150,000 colorectal cases a year and 66,000 urine cancer. So the NCCN guideline call for universal tumor testing for all colorectal cancer and urine cancer, even though they are much more common and the prevalence of Lynch syndrome is much lower in this cancer. Upper tract, even though rare, have about 5% association with Lynch syndrome. So to me, this is a very cost-effective way to screen for Lynch syndrome in patients. Move to this slide here. And the NCCN guideline is also slowly catching up. So this is in the most recent guideline, they start, the discussion about Lynch syndrome and germline testing are making it way small step in the right direction. Now, this is an area where we need more evidence to guide a clinical guideline. So if a patient with a known Lynch syndrome, how do we screen for urothelial cancer in these patients? Say they have MSS2 or MSS6 mutation. Currently, there is no clear evidence to support one way or another, but one reasonable approach would be to check a urine analysis starting at the age of 30 to 35, and then if they have microscopic hematuria, at least 3 red blood cells or higher, then you can do a high-risk microscopic hematuria workup with CT urogram and cystoscopy. And what are the risks of bladder cancer in Lynch syndrome? Even though bladder cancer is less associated with Lynch syndrome than upper tract, there's evidence that there is increased risk of bladder cancer. This is the Canadian registry that show that the incidence of bladder cancer is much higher in patients with MSS2 mutation. And then this is a Dutch registry study that show that the higher risk is MSS2 carrier, and particularly in men compared to women. Now, the last section, which to me is the most exciting part, is the targeted therapy. So from a systemic therapy standpoint, how should patients with Lynch syndrome be treated? And there are a few cases from Memorial Sloan Kettering where patients with Lynch syndrome associated metastatic urothelial cancer have profound immunotherapy response. So this question become more clinically relevant and urgent with the publications in 2022 from, again, MSK. Only 12 patients in this study, and they get published in the New England Journal of Medicine. Why? Because all 12 patients had a 100% complete response rate to immunotherapy in the setting of locally advanced colorectal cancer. And in this study, which was just published yesterday, a phase 2 trial of patients with all types of cancer that are mismatch repair deficient. They treat the patient with a single agent anti-PD-1 inhibitor for 6 months, and the primary endpoint is complete response at 12 months. So what do they find? They find that, so this study, again, there's multiple cancer types, but let's just focus on the 6 patients with urothelial cancer here. All 6 have a complete response with immunotherapy. But it's also important to keep in mind that it is the tumor phenotype that's select for the treatment. It is not the germline genetics. And in fact, not all of these patients have Lynch syndrome, right? So all of these patients enrolled on this study have MMR deficient, but only 51% of them have a germline mutation in the mismatch repair genes. So it's important to do germline testing and tumor testing at the same time. And lastly, there are biomarker-directed therapy in bladder cancer, and that being erdafitinib for any patient with FGFR3 mutations, as well as HER2-positive trastuzumab. And these are the two studies that lead to this indication. This is the erdafitinib for patients with pre-treated metastatic urothelial cancer. The confirmed response rate in this setting is 40%. And then in patients with either HER2 positive or HER2 equivalent cancer, bladder cancer, the response rate range from 30 to 50%. So let me just stop here because some of these are the mutations in urothelial cancer. We don't really have a really quite understand yet what is the extent of their impact in bladder cancer. And I'm going to save the last couple minutes for questions. Any question? Yes, sir. Yeah.
Yeah, so the question was, what's the role of somatic testing or genetic testing of somatic mutations in kidney cancer? It's a good question. I think most clear cell kidney cancers are kind of self-defined. We don't often do genomic testing in those patients, but we also have like a group of patients with unclassified renal cell carcinomas where we do genetic testing to try and better classify them. And then there's sort of the unclassified, there's the unclassified, high risk or aggressive, and the unclassified non-aggressive. And so at our institution, we do reflex testing in all those patients to do somatic mutation testing to see if we can better classify those tumors. And then I think there are also some other subtypes where you see something that looks clear cell-like, but you're worried if there might be like a translocation-associated cancer or something of that nature that may influence further therapy or further care. And so I think it's very selective that we'll do somatic testing in those cases. Oh, germline testing, just routine germline testing in kidney cancer. So as was shown before, the main criteria for doing germline testing in patients with kidney cancer are patients who are young. So I would say under the age of 50. Anyone who comes in who's under the age of 50 should get tested or should be referred for genetic testing. Anyone who has multifocal cancers, either in the same kidney or the contralateral kidney, they should get tested. Any patient who has a very strong family history of kidney cancer should get tested. I even take patients who have very aggressive subtypes of kidney cancer, and I test all of them. So the aggressive subtypes all get genetic testing. Now, at our institution, it's a little bit different. So at our institution, we have something called an impact test. The impact test is a very specific type of genetic testing that Dr. Trong just mentioned. So when we send off the genetic test, we send off the tumor, and we always send off a blood sample of matched normal DNA. And that's because, as she mentioned, like let's imagine you sent off a kidney cancer to have it tested, and they found a BRCA2 mutation in the kidney cancer. And you're like, well, that doesn't make sense. BRCA2 really isn't associated with kidney cancer. It's very, it'd be a strange variant. But you might say, well, maybe that's the patient's germline because you're sending the entire tumor off. So maybe it's a germline mutation that's in the tumor. So you would misclassify that patient as having a BRCA2 mutation in the tumor. So at our impact test that we run always runs germline and normal DNA together. So now our computer, though, is smart because what happens is it runs the tumor DNA and then it runs the germline DNA and it subtracts one away from the other. And then it's like, well, wait a minute, there was a BRCA2 mutation there before, but when I subtracted it away, the BRCA2 went away. So it's like, that can only happen if it's a germline mutation. So while we get a very pure reading of the somatic mutations associated with the cancer, we sometimes find these other tests in the background. And that causes a problem for us because now we're obligated to tell that patient that we found something we didn't expect to find when we did your genotyping. So we automatically find it, although sometimes we have to ask for it specifically. Can you give us both? So the patient will be tested and we specifically ask for germline. And other times we say, no, we're just testing the tumor. And then accidentally we'll find in the background something happening. And then that raises a bunch of questions that we have to sort out.
That's what I mentioned before in my talk. It's very anxiety provoking, and that's why we rely on our genetic counselors to help us, because you sit there in a room and you're trying to get through a clinic day, and the patient wants to talk to you about their genetic testing, and that's all they want to talk about. Well, what about this? What about my daughter? I've got all these kids. I've got brothers and sisters. What do I do? What do I do? And I say, well, those are all great questions. I don't have all the answers for you right now. That's why we have our genetic counselors. You're going to work with them. And the easy answer to that is I tell them, rest assured though, because we found this gene in your DNA, and we don't maybe know what it is, but now we have a test so we can screen your family members and see if they have it. And if they don't have it, then the good news is they probably don't have anything to worry about. But if they do have it, then we can initiate processes for following them more closely. And it doesn't mean and we talk about this issue of penetrance, right? Penetrance means that just because you have the gene doesn't mean you're going to get it. In some cases, the penetrance is very high. In other cases, it's very low. And so even for like Lynch, there's only about a 15 to 20% lifetime chance that you form a urothelial cancer if you have Lynch. So even though and I just tell them, even if your kids have it, it doesn't mean they're going to get it. So we just have to try and identify it and let them know. And that helps to allay some of the fears and keep them engaged. Sorry, there's one at the microphone back there. And then if you could come to the microphone, because I don't know if they're streaming it or not, but sometimes if it's live streaming, the people online want to hear it too.
Go ahead, sir.
Yeah.
Is it audible? Okay, yeah. So Mike, thank you for the sessions. Actually, it was really, really insightful. So my question comes from a real life patient-based scenario. So, as we are doing more and more of genetic testing, a lot of the patients are also being offered DNA with their RNA being tested. So, a lot of these patients have some questions, when they come back to the clinic for follow-up visits, they are saying, I have an option for RNA testing also. So what is the clinical utility of that, specifically for, prostate cancer in specific, because that's...
So RNA analysis certainly can help increase the sensitivity or accuracy of the testing. So if you're meeting with a patient doing the testing for the first time, we try to push the envelope as far as we can. But first, we need to have a justifiable reason to bill the insurance for the test. And RNA currently is not a justifiable reason to bill the insurance. It is not considered standard of care. NCCN doesn't indicate that we are obligated to offer it. But if you have a patient who meets NCCN guidelines based on their tumor diagnosis and or their family history, then the way some of these laboratories, and there are two that I'm aware of that include the RNA analysis. Now, they say that there is no additional out-of-pocket to the patient. However, that doesn't mean that there might not be more billed to the insurance company. So then ethically, can you offer the RNA to the patient? Well, it's difficult to know, to pull out of these genetics labs, well, how different is the bill that goes to the insurance company? Because I have been told by one lab that some of the insurance companies are paying for the RNA. So we, as a practice, our team, if we are able to get a blood sample from a patient, we are asking for both an EDTA tube and a PAX tube so that we can get the RNA. The one genetics lab we understand is going to bill the insurance and see if they can get some compensation for the RNA. They reassure us that that is not going to generate an additional charge for the patient. So it's sort of walking a fine line, because as clinicians, you have to be able to justify, is this medically necessary? And yet, technically, the RNA or NCCN is not yet medically necessary, even though we know it can help clarify some of the splice site variants so the patient never gets that VUS, that it'll reclassify it as either likely pathogenic or benign, depending on whether they see any normal RNA transcript. And you can find some deep intronic variants that would be missed by DNA alone. Likewise, PRS screening for polygenic risk scores is not ready for prime time according to NCCN. So as a practice, we don't tend to do the PRS testing, even though some labs offer it.
Time. Thank you.